I'll
This
change my
conference will
name.
now be recorded.
Oh, I'll change my name to Marlon Perkins.
That sounds great. That sounds great. I'm not sure what I want to go to, but nevertheless, AnCan is grateful to our sponsors for making the recording possible: Bayer Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics, and also the many members of AnCan who attend these events and choose to support our operations. We couldn't do it without you, and we couldn't make it available without the help from Boykin. Thank you so much for letting us archive these and sharing it. AnCan notes that it does not accept sponsored promotion. Any drugs, protocols, or devices that are recommended or discussed in our discussions are based solely on anecdotal peer experience and our understanding from the medical literature. And we do not and cannot provide medical advice. We encourage you to discuss anything you hear in these discussion groups with your own medical team before making a decision. So we have two new people, and the way we like to get started with that is to go ahead and do a brief interview that I've got, and then open it up to the group for discussion. So, Bruce, we're going to start with you.
Oh, thanks a lot.
Yeah, well, that's easy because no matter what you do and say, it's right because you can't prepare and change your answers to protect the innocents. Um, so, how old are you?
So I'm 68.
And you said Parkland, Florida. When were you diagnosed?
2011.
And what got
Bruce,
you?
hold tight. Bruce, you've been new in this group before. I know you have.
I've never been in this group. I've been in the previous group.
I know you were in the active surveillance group,
Right.
but we also talked to you in the active surveillance group after you'd been in this group, because I spoke to you twice in two different groups.
I've never been in this group. This is my first time.
High risk group, Rick.
High risk group.
Yes.
I've never been in a high risk group either.
Oh.
Oh, yes, you have. You have, Bruce. You've definitely been in more than one group.
Okay, well, we can still go ahead.
I'm pretty good at remembering this stuff. Let's skip through this one real quick, Mark.
I respectfully disagree with your memory on this.
Okay, you can respectfully disagree with me as much as you like, but I know we've talked to you in two different groups for sure.
I've only been in two active surveillance groups. I have my notes in front of me.
So can you share how you got into active surveillance back in 2011 first?
I didn't get back into it's only in the last few months. I was trying to find a group to be involved with. My father, who passed away from prostate cancer, it was a part of Us Two. Then Us Two kind of fell apart, and then Zero Prostate kind of, I guess, pulled part of that in, and that's where I met Jim Marshall. And at the end of that first meeting, which I thought was interesting at best, that it was all over the place, Jim called me right after that meeting, and he and I spoke for 3 hours, and he introduced me to AnCan. And from that, I believe that this particular organization, because it breaks it down into the three specific groups, and then you also have which next week will be my first time being in the men's free speaking group.
Mm-hmm.
I haven't done that yet either, but Rick Davis and I have spoken on at least 2 occasions, but not in this group and not in the high level. So I'm now on my last. I don't know if you want to continue with your questions or you want me to just fill you in.
Well, why don't we go, since it was 2011 when you first got started, or you said diagnosed, how have things gone?
So I had a 3+4 in the left lower lobe. And I was transferred from my urologist to the University of Miami. And there's a team of 3 oncologists and urologists that have been following me since. And then a year later, I had my second biopsy, and I had a 3+3, which is a Gleason score of 6, which is grade 1, right next to the 3+4, which is a 7, which is grade 2. and it kind of stayed there. So he decided to wait 2 years before doing the follow-up biopsy. In the meantime, he asked me to switch from the organization that I was using for my MRIs and to use the University of Miami's MRI because he's doing some research studies and they have some ways of whatever they're doing over there. So I agreed to switch over. And in November of 23 and in March of 24, there were no signal changes. The 3+3 and the 3+4 showed. So when they did the follow-up biopsy in June of 24, there were 5 new cancer locations. 3 on the right lobe, 1 on the far left lateral, 1 in the apex. And all of them were 3+3 equals 6 on the Gleason score. But 3 of the 5 were 80 to 100% of the core, which of course made me nervous. And it also made me nervous that it didn't show up on the MRIs.
Okay. And where was your pathology? Let me ask some questions now. Where was the pathology read?
The original pathology was read through the University of Miami and through AnCan, which I'm loving your group. Through AnCan, it was recommended that I go to Jeffrey Steinberg, was it, or something like that, or Dr. Ming. Yeah, so Dr. Ming Zhu.
Zhao.
So I contacted Zhao. So, anyways, he did a second opinion, and I got that report back about 10 days ago. So he found a couple of things that were maybe a little bit different on the lighter side than what the pathologist from the University of Miami. Also, the recommended, I don't know if you guys recommended it or somebody else recommended to do the Natera genetic testing, because I come from a history of Ashkenazi Jews, which my father died of the prostate cancer, and he unfortunately I don't have his genetic information, but that testing was done with 81 markers, and that's when you have the BRCA1 and the BRCA2, and thank goodness that testing came back negative.
Have you done a Decipher score?
I've done 2 Decipher scores. The first Decipher score was in 2011, and that was in the green, like about 60% in the green. I don't remember the exact number, but on the bottom part in the center, said how aggressive it was. It was a 3.3. And then I wanted to find out how radiation would work. So I met with the University of Miami's radiation guy, and right away he wanted to do an updated Decipher score, which put me into the yellow risk at about 50%. But again, on the bottom part where it says your risk aspect, it was only went up from 3.3 to 3.6. So it only went up 0.3%. Yet the other thing that I'm not as 100% sure I understand, and maybe somebody here can, is that they seem to have those testing. There is one little sentence at the very bottom that said these testings were for men who had radical prostatectomies. And I haven't had any treatment yet.
Yeah, that really isn't relevant. It just means that they have the test that they can follow up and get more information and validate the information that they have. If you didn't do anything, they wouldn't know how accurate the test was. So what advice have you been given as far as treatment or active surveillance at this point?
Well, I've been under active surveillance. Dr. Sanju Punam, who you guys may or may not know, he's been having me on active surveillance since 2022. And when he came in after the last biopsy in June, he's a very upbeat, good, kind, gentle gentleman. And he put his hand on my shoulder and he said, "Bruce, I never expected these results. There were 5 new tumors because nothing showed up on the MRIs." So I said, "Well, what do we do?" And so he said, "Well, let's give it 6 months and do another MRI," which we just did. And I asked him to do it back at the place that I'm comfortable with and the radiologist who I know for almost 20 years that I sent my patients to. And I'm waiting to get those results. And I guess the conversation is going to be detailed on May 7th as to, like, they talked about ablation. They talked about chiro or cryotherapy, HIFU, and pinpointed radiation. When I spoke to the radiologist who does the radiation for the University of Miami in the last 6 months, I didn't really like what he had to say in reference to about that he's basically going to castrate me for 2 years using two different medications, Lupron and Jim. What was the other one? Begins with an A.
Abiraterone.
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 Okay.
And that.
Okay, I think we've got
Yeah.
enough of this story to give you some hints here getting started. And I think one thing I would tell you, if with this kind of finding already, they're saying 2 years or even more than 6 months, or even definitely treat or treat with focal, you're getting hodgepodge mishmash of advice that really doesn't make sense. Um, in terms of diagnosing and potentially getting more information beyond the 3.6% risk that the ciphers showed, there is a test called Artera AI, ARTERA, and that study uses artificial intelligence, the path slides, and other information to come up with a risk for doing active surveillance. The next thing is you mentioned a bunch of treatments. They all seem to be focal treatments.
Well, I was just thinking they had said that the other thing that they were talking about was doing a radical prostatectomy.
Yeah, well, I mean, they're all over the place. None of the things that they're mentioning would be what we would expect to see with the information that we have so far. The focal treatment, whether it's cryo, HIFU, Tulsa, or whatever they come up with next week, tends to have a very high recurrence rate. In this study done by leading people at UCSF with HIFU, they had a 40% recurrence in the area that was treated and 50% overall in the area that was treated. And the studies pretty much show that in all the focal treatment, failure rates at 1 year are about half the patients. Really doesn't make sense to go through an anesthesia for a procedure that is going to fail in a year.
So I have a if I may, you probably have said. So I really have a challenge in reference to I have a pretty strong libido, and the concern that I have is that what I've learned so far or understand so far is that if indeed they do the robotic procedure, the Da Vinci procedure, there is some newer nerve sparing procedures that they have, but you wind up losing half an inch or so of the size of your penis, and that you also, may not be able to have sex anymore.
Yeah. So let me kind of go over that. So yes, you can lose length. If it's a big prostate, it depends on the size of the prostate. The bigger prostate length of the prostate, of the urethral segment that's inside the prostate, is cut out. So the penis can be shortened up to an inch, inch and a half. There's no such thing as nerve sparing. Unfortunately, our prostates never read the anatomy books and studied to know exactly where the nerves are in all the people who go through. So, unfortunately, no matter what they say, there's a reasonable possibility of both erectile dysfunction and incontinence, and that dribbling is not unusual to go on for up to a year. The ED could be permanent, although you have the ability to use shots or implants. I think we need to go back to this issue of treating and whether you need the treatment. Dr. Klotz is one of the leaders in the field on active surveillance, and he's done some genetic studies. And what they found is that MRI invisible lesions, and you can go and Google this, but the MRI invisible lesions just don't have the genetic disorder or genetic propensity to spread. So the fact that you went from 1, 2 to 5 lesions, if they didn't see it on MRI, probably does not, in and of itself, a reason to move ahead with treatment.
Showed up on biopsy?
What?
But it showed up on biopsy.
Yes. Yeah. Not all. I mean, if you look at people who have 3-3, the majority of them never come to treatment if they do active surveillance, unless a urologist pushes them or they just get tired of following. Most of the time, if you do not have a significant increase in PSA or in other biomarkers that can be used, or the MRI, just routinely doing biopsies is probably a thing of the past. Was it a transrectal or transperineal biopsy?
First one was transrectal, and the last two was transperineal. So there were
Okay,
12 cores on the first one and 16 on the other two.
So again, that seems it's a standard template biopsy, and most places are getting away from that. But I think the Artera AI is a good thing. And in terms of surgery, this is my bias. So I'm speaking on behalf of myself and not the other people in the group. I am a minimally invasive surgeon by training, but I walk into an operating room when I absolutely have to, and I know there are no other alternatives. And while radiation can also result in erectile dysfunction after 2 or 3 years, you don't have the immediate risk of anesthesia. You don't have the surgical problems. You don't have the incontinence. And you walk in the room and you walk out the room. I
was told that there's two different. There's I forgot the names of, but one's 5 sessions and one's 25 sessions.
Yeah, SBRT is with the 5 sessions, and at University of Miami, I think they have the ViewRay.
One's Proton.
You know, the Proton is there's no advantage to Proton. That's another hype. When a system has a Proton machine, they spend an awful lot of money, and they have to recoup it. So if they can do 40 sessions versus 5 with either CyberKnife or one of the MRI Linacs, oftentimes they'll do 40 to pay for the machine. There's no advantage. The Partiqual study, Partiquol.
One more time,
Partiquol.
Study.
That compared IMRT with Proton and with Photon, and there's no advantage. There's no decrease in side effects. When you sit in front of a Proton machine or under a Proton machine, all the energy comes through 2 pathways. If you're sitting in front of an MRI Linac, it's 15 beams. And when things move, the beams turn off. With the Proton, they don't turn off. So if you have a gas bubble moving through, it's dumping all that energy right at the end, but that end may not be the target. The other thing is the side effects to the bladder, to erectile dysfunction, have to do with radiating normal tissue that surrounds the tumor. With CyberKnife and with an MRI guided Linac, they cut that extra margin that's around the tumor, so you're radiating less normal tissue, and you're spreading
that's almost like a moles type surgery.
No, well, not really.
Well, because moles you're doing to make sure you get the out.
But you're not cutting anything out. You're not cutting anything out. They just add a margin to make sure that if there's any movement, you're still treating the tumor. The problem is you're also treating more normal tissue. And with the MRI Linac, that's not the case. University of Miami, I think, has an MRI LINAC. I know that there's.
I'm not catching the same. It's called a Linic.
Yeah, LINAC is the beam coming in other than proton. If it's a photon, the machine is called the LINAC, LINAC, and the aim is with an MRI. So it's an MRI LINAC machine. And I know there's one in Miami. I think there's also one in Boynton Beach. But I don't know that you need treatment. But let's see first what questions you have for the group, and then we'll see if there are comments. I don't see any hands up yet, but what questions do you have for the group?
How are you gentlemen addressing a sexless lifestyle? How do you come to terms where part of my identity and I have at this point, a very strong libido? And then all of a sudden, if you turn around and you either do the radiation, you get castrated or so on and so forth, now all of a sudden that part of my manhood, I guess, is gone. How have any of you, if you're willing to share, how have you come to, I guess the first question is, if you're willing to share, are any of you able to perform? That's one. Number two would be, if you can't perform, or not, I don't mean in a negative way, I'm just messed up in my brain a little bit in reference to, do I want to live and die and maybe live 3 to 4 more years or 5 more years under active surveillance, or if it goes out like that, and I'll be in my 70s at that point, and then I've had a great life and so on and so forth. So as I spoke to Jim earlier in the day, I said to him that I'm now more 70% leaning towards being able to do the prostate surgery. I don't think I want to do full-blown radiation. So I guess my question is, of the gentlemen who are, and you don't have, of course you don't have to, but I only know one person out of over 100 men that I've spoken with who are still able to have sex.
Well, first of all, let me comment, and we do have a bunch of hands up now. First of all, I was on 6 months of abiraterone and Lupron. And during that time, it was supposed to suppress my interest. It did not. It did suppress my ability, but I entered into this with low T. I'm 74 now. I'm not sure if part of the dysfunction is age related, which I had before. It's pretty much no different. And we've learned to accommodate. Is it the same as when I was 35? No, it absolutely not. But the one thing that I will tell you for sure, if you're a 3-3 or 3-4, they're probably not going to advise you to even consider ADT or abiraterone. So doing surgery, you can end up and never have an erection again. Doing radiation SBRT with a newer precise machine, some people never get it. It's 30 to 40% versus over 50%, and it's late onset. And there are other ways to have sex that don't require having an erection like we did at 35. Let me go and open up to some of the people who want to make comments, and we'll get back.
Please, thank you, Mark. Appreciate your information and being open and kind to me. Thank you.
Yeah. Oh, Stuart, you dropped out. Did you want to talk?
Yeah.
Go ahead.
Well, Bruce.
Hi, Stuart.
Hi. How are you? I was treated in New York. I'm in a trial that's both focal treatment and SBRT. But the conversations that I had with the doctors at both Weill Cornell and MSK, the beginning of this conversation is, it starts with where you are prior to any treatment. That the better or less that you're able to perform before has a lot to do with where you'll be if you come out when you're after post treatment. And, given all the other age related pieces of this, it's not everybody before is not going to be able to perform after. It's gradation. Now, I have friends who have had surgery and, they don't necessarily have a great situation afterwards. One of the things that the radiation oncologist told me was, be prepared for the fact that post treatment at some point you're probably going to have dry orgasms and no ejaculation.
Yeah, which is fine with me because at least that way you have the serotonin, the oxytocin, and the dopamine release, which is what orgasm is. Whether fluid comes out or not, that I'm not as concerned about that. I'm more concerned about having that feeling. Well, one of the last few things that I have is, I guess, what I consider being a Jersey boy, about being rough and tough and being a man. And being rough and tough and being a man was always about having sex. And so I know I'm working diligently with my therapist in reference to working on a shift in my thought process.
Well,
have you discussed it? Oh, sorry.
Go ahead.
Have you discussed with your partner and involved your partner in that discussion?
Yeah, my partner is 6 years my senior. She has no really interest in sex. She has we're under care of a therapist for a number of months for care, but recently she on her own said that, listen, if you have the surgery and so on and so forth, I'll do whatever is necessary to assist you. So that was very kind of her to say that. What that looks like, no clue. So I do know that the head of the penis has nerve sensitivity inside the thighs. The cremasteric reflex has, testicles have. So what I'm hearing is that you don't have to have a full erection to be able to have pleasure.
Absolutely. Absolutely. Let's go ahead to David. You're up.
Thank you, Dr. Mark. Hey, Bruce. What is your PSA?
Hi, David.
Hi. What is your PSA?
Well, my history of my PSA has been all over the place. I have had 19 bouts of prostatitis, and started when I was 19 because I used to do triathlons, and the type of bike would be very hard, and so I have both mechanical and bacterial prostatitis. So for back in 2023, 22, I was like 2.2, 2.4, 2.6. And in June of 23, I jumped up to like around 3.8. And then it went up to 4 point something, but I was having full blown prostatitis. And the urologist I was seeing at that time basically used to give me Leviton. And that, with 2 sets of treatments, 3 weeks of treatment, that would bring it back down. So most recently, it's been going anywhere from 3.4 to 5.2, and then back down to 3.6. And the 5.2 is I made the cardinal error of being intimate with my wife the night before I had the PSA.
Got it.
So I just that was about 6 weeks ago. So the one before that was 3.8.
So I'll share with you my experience. I was a 4+3. And I elected to do a prostatectomy, which I wish I never had done, because it affected my sex life quite a bit. And if I had a choice of redoing it, I would have gone right to radiation, and I would have been able to maintain most all my sexual function. I also have figured out how to do. There are other ways to do it. I use shots, and there's other ways to get intimate. But I can tell by talking to you, it means a lot to you. But if you have to choose treatment, I would not have done the prostatectomy. I would have gone right to radiation.
What type of radiation?
What's that?
What type of radiation are you talking about?
I did 45 sessions of
the proton.
The whole, not proton. The whole prostate bed. It's not SBRT, it's the other one. I forgot what it is. What is it?
MRT.
Yeah, yes. So
Well, I missed
IMRT.
it. What was it called?
I think it's IMRT, isn't it?
IMRT. Yes.
IMRT.
One
So
more
if
time.
I had a
I'm sorry. I'm
choice,
sorry. Well, I'm trying to write it down. MRT?
IMRT. It's really not important because that's down the road.
right?
Um, now, David, when you had the IMRT after the surgery, was that right away or was that when it recurred?
It was when it recurred, and it was probably a year after.
So I think the important thing that hasn't been said yet is that even people who go through surgery, a very significant number of them are going to turn around and need radiation anyway. And then you get a
Correct.
double whammy. So, in addition to all the time you had to recover the erectile dysfunction, then you had to go in and start with the radiation again. And the numbers don't, the names and the initials don't tell you anything.
Right.
I've been studying this for 3 years, and radiation treatment after the prostate is out is far more difficult than going in when you have a prostate that you can push out of the way with a gel that you can do genetic screening. I'm sorry, go ahead,
Right.
David. I interrupted.
No, no. So you're spot on. So your fear, Bruce, you should research a little bit more. But radiation, if I had an opportunity to reverse what I did, I would have gone right to radiation. They could have just radiated the gland itself, and so I had to wait because it had already the tumor had already been outside the gland, so I had to radiate the entire prostate bed. But if you have to do treatment, you may want to really study the radiation. It's not terrible at all. It's a million times better than the prostatectomy
I appreciate
Okay.
that because I have a friend.
from from a side effect standpoint.
I have a friend of mine's best buddy who I've spoken to who wound up having a prostatectomy at 38, but they didn't take the seminal vesicles out or a couple other things. And 10, 15 years later, he wound up having cancer at the base of the bladder. Anyway, so the same gentleman at the University of Miami was who I was talking with. It turned to be that he went through 2 years of radiation and he was on both of those medications too. So he was castrated for those 2 years. And
But that's a totally different story, and it's not very helpful to come in with something as different. The one thing that we can do here is hear your story,
no, I'm
and
just trying to,
from the
yeah, but I'm just trying to get an idea of the radiation. I had kind of like, as I told Jim earlier today, I definitely wasn't going to do radiation based on his story. But if there's other different radiations that I can research and that
yes,
might,
MRI Linac is what you should do. If you Google go to YouTube, and there's Dr. Kishan, Kishan, and he has a number of YouTube videos on SBRT, and watch those videos, and it will at least give you information that you can come up with and ask the right questions. Let's move on to Nick.
So that was UCLA where Dr. Keyshawn is from, right?
Yes.
So, and I've seen some of his YouTube videos, Dr. Bruce. And so that's a really great recommendation that Mark Perlow just gave you. Are you familiar by any chance, Bruce, with PCRI,
no,
Prostate Cancer Research Institute?
PCRI. No.
Yeah. Okay. So check out that website, and I'll give you a very short introduction to myself as it relates to you. But really, as Mark said, other people's situation, they may be useful to you, but mine, Mark's, this guy you were talking about a second ago, they're not really relevant to you. There are things that are important. So anyway, back on the PCRI thing, there's like conferences that they've had. Like I went to one last September, and they also had and you can look at these things online, and they have a lot of videos as well online on prostate cancer and the radiation choices and the different focal therapies. So you'll probably be quite interested in them as someone who's looking into your situation like you are. And with that said, The reason I was bringing up the PCRI thing is one of the things I learned there, and Dr. Klotz being one of the people who really emphasized this, was that someone in a situation a little bit like yours, meaning that's 3 plus 3, there's a 90% chance you'll never need to do anything.
I do have one
Now,
3 plus 4 though.
I see. Okay, you have one core that was 3 plus 4. Was that 80? Was that 80% of that core, like you said?
Oh no,
before?
no. That was 17%, and it's now 22%. But that was the original one from
Gotcha.
2011.
Okay, so did they? So I realize that you're concerned about this, but I'm still going to say the same thing.
Please.
You should really be careful about going forward. Do this AI thing that Mark Perlow advised you to do, the Artera thing, and do all the analyses that they have available. I did the same thing. It can be reassuring what's not there, like you were talking about the BRCA not being there and stuff like that. So those are reassuring things. My point to you, okay, before I go on, I'll say, similar to Stuart, I also got in this clinical trial that was in New York where they did IRE, irreversible electroporation, and then they did a reduced amount of radiation. In our case, it was MRI guided SBRT. There are more than one style. I know you were talking about the LINAC, Mark. There's more than one of them that are still good for you. So there are other opportunities. If I was you, I don't know if you've looked into the Mayo Clinic up in Jacksonville at all, but I think they're a center of excellence. Is that right, Mark and Rick?
Yeah, I'm not impressed with what I've seen coming out with radiation therapy there.
From Jax? Because they're the
Yeah,
ones who are supposedly putting in the
I haven't seen
accelerator.
the publications or participation in the major trials on radiation, and some of the stuff I've heard has been a bit off base. So
So be careful.
I'd be careful.
Right. So, I mean, that's sort of my point to begin with. Keep looking into things intensely the way you seem to be and interested the way you seem to be. But if I was you, so I'll shut up about this now. If I was you, I'd be very cautious about moving forward with treatments in your situation. You may be a person, I'm not trying to tell you not to get treated. And I was someone who didn't want any radiation. But I got to tell you, these guys are right about what they're saying. I'm not saying it because I'm trying to patronize them. A couple of people on Rick and Mark will tell you I'd be ready to disagree with them in 2 seconds. I'm telling you, they're telling you right here. Try to stay away from the prostatectomy. And if you need to get treatment, look heavily into the different radiations, but do make sure you get at least MRI guided radiation. I would look into the focal treatments if I was you. I'm not telling you that that's the winner. I think the information they gave earlier in this conference call was accurate. A lot of recurrence happens with focal therapy. However,
So why would that be recommended to do that?
it depends on your situation. In mine, and I'll speak for Stuart for a second, in mine and Stuart's situation, we were less than 5% for. We're 3 plus, and we're 3 plus 4s, but you're a 3 plus 4 too. You might be less than 5% for as well, meaning of the amount of cells that are showing that type of formation that I only had 3% for, and the rest of it was all 3 plus 3. So I had a very specific target they could go after as well. So, but I also got in this clinical trial where I got radiation to back it up. The Ricks and the Marks of the world would tell you they think it's the radiation that's really working and not the focal treatment. So I'm not telling you to go for one versus the other. I'm telling you,
You're giving me a broad spectrum of information, and I appreciate it.
the big thing I'm trying to tell you is, in some regards, well, I'm also from New Jersey. Where are you from?
Jersey boy. Union.
Oh, I'm from Ridgewood, if you know where that is.
I do.
At any rate, and I'm also from Florida, from
Nick,
Tampa.
Nick, I want to let
I'm
others
finished. I just want to make
in
sure you
there.
heard me say
Yeah, and
that.
I want to make sure
Make
that
sure
you're
you
3+4.
and don't go too far without making a lot of cautious decisions. And I'm
I
I'm
want
finished.
to
just
make
curious. If you were 3+4, why didn't you just stay under active
Look,
surveillance?
we've got to move along, Bruce.
I could have.
We've been 45 minutes. We've got two more
Okay,
people who want to
Rick,
make comments. We're going to
let's
take those two people, and then we're going to move along.
okay, John.
Oh, I took my hand down because uh,
Okay.
it's the same as I completely agree with Nick and David. If I had such minimal disease, I would not do any treatment.
I think the other important thing is you're saying 3+4. If it's a University of Miami 3+4 and Dr. Ming Zhao says they're all 3+3s, because you did say that
Well, he
it
said it
was
was a 3+4, and the rest of them were 3. But
okay.
the value of the cores he felt were not as
Okay.
full.
So again, that's why I think Artera would be a good place to get some additional information. Stuart.
Yeah, I just want to go back to where I started in my journey because my numbers were originally very similar to yours. And the whole focus at the beginning was this first question: should I treat or surveillance? And my experience was, and I think unless you've done it, that going and see uh, enough doctors at centers of excellence that are open to surveillance and are also open to treatment and get their opinions, because I did that, and to a person, my my doctors all told me, yes, you should treat because your decipher's high enough and at some point you're going to have to treat. But my brother, who's following in my footsteps, unfortunately, has gone and seen doctors at MSK and doctors at NYU. And to a person, they look at it and say, there's no reason to treat. So I would focus on that question as opposed to which treatment. There's plenty of time, if the conclusion is yes, you have to treat, to then to consider the different choices. But it sounds like you're 2 steps ahead of where you need to be.
I think that's important, Stuart. Thank you. Let's move on now. Robert, you've heard a little bit about the grilling. So hopefully you will survive that. Where are you located?
In New York City, Manhattan.
So you've got excellent resources. How old are
I
you?
do. I'll be 70 in August.
Okay. Don't rush it. And when were you first diagnosed?
In January of 2008.
Okay. And what have you done from then since up until now?
Very aggressive. I had my prostate removed in April of '08 by Ash Tawari, who was at Weill Cornell at the time.
Okay. And how did things go after that?
PSA was low in June of 15. I had recurrence. So in about 35, 40, I just can't remember treatments, IMRT, that was done by Richard Stock, hit a grand slam, brought it down to 0.02. Since then, it's just been rising. I've had 5 PSMA scans, 4 Axumin scans. My last PSMA scan was in January, 2 months ago. My PSA at that time was 2.88. As of last week, because I go 3 months, is 3.36. And for the life of me, MRIs clean, bone scans clean, the PET scans clean.
Okay. Normally we would have you go to the high risk recurrence group. We tend not to get into this as much here. But
Excuse me, Mark. I did through David Muslin. I did have I did speak to the high risk group, and Rick
Right.
gave me some good advice. The same thing with the doctor said. Just watch. Just
Yeah,
watch
but
it. I wasn't.
Robert, let me explain to you why we don't discuss this here. There's a really good reason. Because most of the gents in this, and this is why we separate our groups, the gents who are in this group have not been treated yet. Or they have been treated and they're dealing with immediate side effects from the treatment, which could be ED, could be incontinence. They still have the hope of their disease not recurring. We don't talk about recurrence in this group because we don't want to disillusion them. The same way we don't talk about treatment in the low risk active surveillance group. Now we have a group tomorrow at 6 o'clock, which Dr. John will be leading, right, Dr. John? And we're happy to talk to you about what to do next in that group. But we really don't want to discuss it in this group, not because we don't want to help you, but because it's not healthy for all the other guys in the group.
Yes, I apologize, Rick. I suggested that Bob came to this group because when we had him in the advanced group last time, maybe a year or so ago, I thought maybe he was out of place there. So it's on me, and he's absolutely right, Bob. Tomorrow we'll come on the same time at 6 o'clock tomorrow night Eastern time, and you and I'll get on together tomorrow night.
Okay.
I apologize.
Not the same time, David. 2 hours earlier.
Oh, it's at 6 o'clock Eastern.
Eastern.
Right, tomorrow night.
Yeah, 6 o'clock
6
Eastern.
o'clock Eastern tomorrow
And,
night. So
you know,
I'll be on anyway, Bob. It's on me, guys. Sorry about that.
That's okay. Let me just say, for certain guys, and I had a guy who reached out to me just recently in a similar situation. There are some guys that kind of fall between the cracks because they're not high risk, and they don't really, and they're not advanced, but their disease has come back. But we just made a decision many years ago that if you had recurrent disease, we didn't want to talk about it in the low intermediate group.
I'm sorry for that.
That's okay. It's not your fault.
Okay, I want to move along here. I wanted to check with Jay and also Paul if either of you are going to need some time this evening. Jay?
No, I'm kind of okay. I chimed in late, sorry.
Okay,
I forgot.
Paul?
And I'm just doing the genetic testing. I'm waiting for it to come back. That's all. Thank you.
Fantastic. Yep. Paul, are you going to need some time?
There's two Pauls, but no, this Paul.
Okay,
good.
Which Paul are you?
I'm just Paul. There's a Paul N.
Right.
Okay, but no, I'm good. Thanks.
Okay, great. So let's hear from Greg in Detroit.
Oh, thanks so much. Two quick questions on SBRT treatments. As we know, the SBRT treats the whole gland, and I guess I was wondering, is post-treatment, what effect does the exercise and sex have on the PSAs subsequent to treatment, seeing as that the treatment is to essentially treats the whole gland. So I was wondering if there were any comments on that. And then also too, in relation to the PSA rise after treatment, listening to Mark Scholz's webinar in relation to the ebb and flow of PSA post-treatment. It wasn't quite clear to me in terms of how frequently is the PSA rise seen in a post-treatment situation, and approximately how long after the last treatment does it occur, if it were to occur at all?
So I'll take the second one because that's easier. The PSA rise can occur anytime up to 2 years, and a single value that's up is not a concern. But if you have 2 or 3 consecutive rises in the PSA, that might be concerning. You can also ask, because there is some information about what kind of drop you should see by 6 months after treatment, and that may be predictive. Um, as far as the percent, I'm not sure what the exact number is. It's not unusual to have it bounce around. Recurrence has been traditionally defined as a rise of 2 in the PSA um, after the nadir has been reached. I think most people ought to check a PSMA PET before then, and not let it get that far out of hand. But that's something you might want to decide or discuss with your radiation oncologist. Um, Anybody want to tackle the first one about how labile the PSA may be after radiation treatment?
What do you mean by labile?
Bounce around with sex or diet or anything else?
I think even without sex or diet, it can be quite unpredictable after radiation, and you really need the big picture.
So, how much, John, would be monitoring too frequently, and what is the ideal interval of doing the test?
I guess 3 months if the risk is high, intermediate, or higher. And I mean, some people go 6 months for very low risk. I'm never very comfortable with it, but I know a lot of doctors do 6 months in the low risk area.
Yeah, I'm on a 6 month interval myself, post treatment, and I came down from an 11.8, which was actually at the last reading. From the last reading was 2.7 from an 11.8 pre-treatment with 12 months prior. So and I guess in some respects from the last discussion, they can expect it to go down, but I guess I was wondering in terms of activity, is it the same? Does activity affect the PSA readings post-treatment the same as it would pre-treatment?
I would guess probably not, because a prostate gland that has been decimated by radiation is probably not going to be able to produce PSA in response to riding a bicycle or having sex as much as a healthy gland. I'm guessing, though.
The
Yeah,
other thing that's interesting with that is that the cells, when you do radiation, they don't die immediately. They're not like, okay, you got your last dose, they're all going to jump off the cliff and die. What happens is over time, the cells try to divide and grow. And it's only when they're doing that growing phase that they actually realize, oh, our DNA isn't any good. We can't carry this out, and the cell dies. Um, Whether the PSA is produced before the cells divide, or they divide and release PSA that's inside the cell, I don't really know. But I would think that most of the variability that is seen is just from cell death in the process of how radiation works, rather than Someone's got their mic open and a lot of noise in the background. So if you do, please try and mute.
Okay, guys, we're good on that. Thanks.
Okay. Paul, Ann, you needed some time. I don't know what this means. On my screen, it says on a call.
Yeah, he's probably joined with his phone, and he's gone over to another call on his phone.
Yeah,
So
maybe.
we'll come
Okay.
back to him.
Actually, he's on twice.
Yeah.
Oh, he is on twice. Yes. I don't know.
Okay. Michael in Tennessee.
Oh, hey. I'm sorry to bother you guys again. I'm currently on active surveillance, and just to run through this real quick, I'm a 3+3 from Epstein in 6 cores. Came back with a very low decipher score. Promise color study is negative. PSMA has been negative for spread. All this is based on just having a high PSA and then instantly going and putting me through a 17-core biopsy. With no MRI, no prior imaging. They just kind of started poking around. And I finally had a actual 3T prostate MRI, and they showed a 10 millimeter Pyrads 5 lesion. So as of now, I am treating this based on just the information I have and just going the active surveillance route. But I'm using this time to kind of doctor shop, I guess is the best way to put it. For the long run, right? Whatever that, hopefully as long as possible, right? And so I've reached out to MSK and UCLA. I do have time scheduled with Eastham and Nagar in late June, but they can't do telemedicine, and so I have to make the trip from Tennessee. But UCLA just got back with me like late Friday, and they are able to do the telemedicine as long as I have a licensed physician like present in the call. And I was just curious how much stock you guys put in, like how do you weigh out? I'm really just after kind of a second opinion on all this and somebody to work with in, like I said, for the long run. Would you weigh out the telemedicine, somebody I can talk to anytime quickly, and then go visit as needed at UCLA more than having to take the closer trip to New York?
Well, I think it's an interesting question, and find out what kind of license. Does it have to be licensed your physician or just a license?
But licensed in my state, right?
So, okay, so I won't volunteer to do it. I'm not moving to Tennessee.
Right.
If it could be a California doc, I'd be more than happy to hang on the call with you. What strikes me as Decipher is a tissue test. It was done on a piece of tissue that was gained or collected by doing pin the tail on the donkey, and not someone who wasn't blindfolded at the time they did the biopsy. So to say you are a great case for active surveillance simply based on the Decipher score doesn't necessarily make sense to me.
No, I agree. I'm sorry to interrupt, but I should have mentioned that I've had to wait for my prostate to heal, and I am going back for a fusion guided targeted biopsy of the lesion in June as well, in the middle of June.
So it would seem like you'd want to repeat the Decipher on that sample from this 5 lesion, and it may be putting the cart before the horse to talk to someone like Nagar, who is a radiation oncologist. If it turns out that 5 area, when they biopsy it, is still Gleason 3+3, I don't know. I'd be interested to hear what other people say. Jim Stewart, you've got your hand up. Go ahead. Unmute, please.
Okay, sorry, I hit the wrong button. I just want to say about the telemedicine thing. I do almost all my care through telemedicine. I live in Reno. My surgeon and the referrals are all in San Francisco, and we do them all by telemedicine. So I'm a big proponent of that, and don't let that the idea of telemedicine affect your decision to not go forward that way, because I think it's a huge benefit, and I highly recommend it.
Okay.
So, Michael, I do want to offer a couple of thoughts. I kind of agree with what Dr. Mark is saying, is that you don't want to put the cart before the horse. And I think that jumping to these docs at UCLA and even going to see Eastman Nagar at this point in time, when we don't even know if you need treating, is not the way to go. I think, well, I won't say Eastham, I will say Nagar, because what you really need is a good quarterback doc who can hold your hand through active surveillance, and Dr. Eastham is definitely fits that bill. Definitely fits that bill. However, you can't see him if you're not in New York, and so you've got to find somebody who's within striking distance. Now, I should say you can't see him if you're not in New York. You'll have to go up to. You have to go up for the first time. I don't know about subsequent times, but I think that the way MSKCC at least works, you've got to you've got to be present in the state, I think, but I'm not. I'm
I
not.
was told as well. Right.
They definitely do telemedicine, but I think you've got to be in state for telemedicine. So, what we really need to find for you and is somebody within reasonable striking distance of Knoxville. You're in Knoxville, right? Correct?
Chattanooga, but yes.
Chattanooga. Sorry, you're in Chattanooga. Yep, Chattanooga. You need to find somebody within reasonable striking distance of Chattanooga who is empathetic to active surveillance. And that's where I would be focusing my efforts. When you come on these groups, you hear about all these great doctors all over the country, but they're not necessarily the doctors that are right for you, depending on where you live and what your situation is. So, if we, for example, could find a good doctor for you within a 2-hour drive, that would be a much better option than anything you're dealing with. That would be my contribution.
Does Vandy have anybody in that category?
I don't know. I don't think so, but I don't know. The way to find out is to I'd have to do the research, but Michael, you can do this too. Is look at Vanderbilt and put in Vanderbilt active surveillance prostate cancer, early or pre-treatment active surveillance prostate cancer, and see what comes up, and see if there are any docs in there who are doing studies on active surveillance at Vandy. I think that's what I would do to check out Vanderbilt.
Okay.
And then I would go there. And are they the very best that's available? No. But you've got other factors that you've got to consider, that, and it's going to make your life a lot easier. I mean, how far a drive is it to Atlanta for you? 2 hours, 3 hours?
Yeah, like an hour and a half, 2 hours.
Hour and a half. And isn't there I thought there was one doc there that was good, that was okay.
I don't know. I mean, I'm thinking the real issue is if you go and you get a Gleason 4+3 on biopsying this 5, you don't
Yeah.
care if they're active surveillance or not. So I really think you need to get the biopsy, Dr. Zhao or Dr. Epstein to review the biopsy,
Yeah.
and then
Right.
figure out what's going on
Right.
to decide what kind of doc you need.
Right.
That's something I considered initially. I was hoping to establish at least a hello with somebody to begin with that could help me in either situation, right? but
Yeah, but
but
we don't know where it is, who it
right.
is, and where it is, and I think this is more one that falls into Dr. John's area of expertise. That we've got to help you manage the anxiety around the diagnosis, which is to some extent what's driving you right now. We got your back. This ain't going to get away from you, and we'll get you to the right doctors when we know what exactly the issue is. But we don't know what the issue is. I mean, Dr. John, do you have anything you want to add to this one?
Well, just that our brains are too big, and therefore they have the ability to anticipate problems in the future and worry about them. And it's kind of too bad. So, yeah, if you want, you'd be welcome to come to Men Speaking Freely, talk about the anxiety and coping. Because right now there's nothing you can do until we get more information about that, about whatever that MRI picked up. So let's wait for that report. And in the meantime, try to distract yourself and exercise and have a good time, and we'll see what it is when it comes up.
Well,
it's not something that you need 3 months, 6 months. It could take. I started my radiation 10 months after I had the biopsy that came back positive, and everything has gone well with it. So you've got time here, and sometimes stepping back and taking it one step at a time allows you to make the best decisions, which are it's going to lower the stress, and you won't start off with an active surveillance doc and then need to find the best radiation oncologist and start over again, particularly with having to travel, wanting to travel to get the care and see top people. Wait till you have enough information to empower them to use their greatness on your behalf. They don't have that now.
Well, I didn't mean to imply that I was anxious about it. I feel great. I'm eating better than I have. I'm exercising. I'm doing all that stuff. I feel good about it. I was definitely talking fast to try to get all that off my chest and not waste y'all's time. but yeah, I'm good mentally. I feel really good about it. You guys have been amazing. I absolutely appreciate everything, Rick, John, Mark, Stuart. I mean, everybody on here has been great. And so if you say,
I got a doc for you. I got a doc for you at Vanderbilt.
Okay.
How's that?
All right.
So, and I'm gonna put his, and I did exactly what I suggested to you, and I'm gonna put him in the chat window right now. His name is Daniel Barocas, and he's a urological oncologist at Vanderbilt, and he has done studies on active surveillance. Sounds like he strongly favors active surveillance. You can look him up. You can read some of the studies. Let me find here's the study that I just found. Here's the study I just found, and it sounds like this study shows active surveillance preserves quality of life for prostate cancer patients. I mean, that's the sort of doc that you want. I don't know him. I don't know what his bedside manner's like or anything else, but it would suggest to me that he might be a good start. So you can click on both of those, and there's a couple of people close to home.
Great.
And keep working with us. But I think both of those could be alternative. Dr. Barocas could be an alternative, and there's probably more. If I just put in Vanderbilt active surveillance, prostate cancer, and there were a couple of links, and I went to a couple of places and found Barocas had done some studies. So he's probably their active surveillance guy.
Gotcha. Okay. So
Okay.
collectively, what
That's
we're going
great.
to do
Good
right
luck.
now is just to figure out exactly what I'm dealing with once everything's
Yep.
healed up.
Yeah,
And then,
yeah, and if you've got a guy like that, like a Barocas, who's on your team already, and he's going to guide you to the right treatment as well. At the time that you do need treatment.
Okay.
And maybe we've discovered another great doctor for our Tennesseans.
I hope so. It's hard to find one in this area.
Yeah, I would wait to have an answer and then see what he suggests so that you understand what kind of equipment they have. In LA here, we've got City of Hope, where if you go to City of Hope, you'll get great radiation care. But if you go to the strip shopping center that says City of Hope and they have a radiation machine, it may not be the same thing.
Right.
The same in New York, you go to MSK and you see Dr. Nagar, you're going to get great care. If you go to the MSK satellite in New Jersey, it may not be the same thing. So get the answer of what's going on, and then we'll, give you some comments and see what the docs say there at that point. Paul N., you were on before, and I'm not sure if we missed you.
Yes. Okay. I just want to give you guys a update on my stats. So I did have my radiation treatment completed in early January. So 3 months, did a PSA, which is a week ago, roughly. So I went from around a PSA of 9. Okay. First of all, the treatment I got was a 28-day hypofractionated external treatment. So PSA prior to treatment was around 9. After treatment, 3 months, check, it went down to 1.06. So quite a bit more than I was actually expecting. I would have been happy with a 5 or 6 because I know radiation tends to go slower than prostate surgery removal. So did a consult with my radiation oncologist. He was a little bit pleasantly surprised as well. So going forward, they recommend 6 months follow-up, again, PSA, and then have a consult with him afterward. Side effects wise, just summary, I had a little bout with rectal bleeding, second week in, which is a little earlier than normal. Got me on the suppository. It took care of that. With about a week and a half later, went away, hasn't returned. And as far as urinary, I've been on Flomax also since day one. Flomax seems to be working well. So far, no side effect. Nothing came back as far as side effects. So we'll see what happens going forward. And once again, check a PSA test in 6 months from now, and hopefully it stays down or go lower. Now, with regard to nadir point, yeah, my doctor said, yeah, you want to go below 1. But he said he's good with staying above 1 or hovering around 1 as long as it remains stable there. Going forward with further future tests. Obviously, as somebody already mentioned earlier, is once you're a nadir, you want to stay there. It might vary a little bit up and down, and maybe those PSA spike, which I'm ready to for those as well. So So that's the summary. Looks good so far. I'm glad. I just got lucky, got blessed. So we'll see where I'm going forward.
Paul, did
And
you
that's it.
use the gel?
Oh
One
yeah,
of the
there's standard practice. Yeah, yeah. Spacer, bear gel. Yeah, and then of course the traditionals too. Yeah. So I did the 28-day, as I mentioned. I couldn't qualify for the SBRT decide because I did have my the prostate test, and that came back that I'm high risk for GU and GI issue with the 5 course extra dose, strong dose, and also the prostate test also indicated um, I'm low risk for the long term. I mean the longer treatment. So it all kind of worked out.
Now, was that something you heard from us here, or was
Yeah.
that something your doctor had recommended?
The prostates.
Yes.
Yeah, it's either from you guys or I do a lot of research. It's just the way
No,
I
it
live.
was
So
it was from here, Paul. I pretty much recall. I mean, the reason Dr. Mark is asking is because we are planning a presentation um, with the Prostox people to talk about
oh, really?
what
Okay.
that test offers. It's a little different to some of the other things in that it's the only test available that offers that. So we can't even send anywhere else. And I was a participant in a presentation from Dr. Weedhouse about 2 weeks ago. She was really impressive, and now Dr. Mark is meeting with them and her, and we're going to have her on for 45 minutes or an hour before the beginning of one of the groups, and do
Okay.
a little education session with for people that are considering
Yeah. Okay, that's
radiation.
good. Okay, yeah. So probably I heard from you, and actually, I had a teleme session with Dr. Keyshawn at UCLA. I think he was one of the original
Yeah.
people that were doing the study. Yeah. So that was the part of the reason I wanted to talk to him. So because my radiation oncologist, when I talked to him earlier, I mean, before, the year before treatment, he said, I know very little, and he's not going to write me an order because he doesn't know much about it. But so when I
Yeah.
talked to Keyshawn, he automatically signed me up for it.
So
So
for those listening to the recording and those in the group right now who are wondering what we're talking about with respect to Prostox, Dr. Mark is one of the earliest proponents of Prostox because it only goes back about 2 or 3 years. Mark, do you want to just give a quick explanation of what the Prostox test is and does?
Yes. The Prostox test, I wouldn't describe it that way because when it first came out, I hadn't seen enough data to be convinced. But the Prostox test consists of 2 genetic panels that are used to predict late side effects after radiation therapy. And the side effects that they see are based on the dose rate. So that there was some concern that some people who got SBRT, which is 5 doses of radiation, versus doing 28 doses, are at greater risk for side effects. And it turns out that it's about 7 to 9% that may be at greater risk. And the first prospects panel will say, you are at a greater risk, and you should look at spreading it out with a lower dose per day. And they have a second panel that looks at side effects with that. Um, they have had people who have done both tests, and it turns out that their mutations or genetic makeup puts them at greater risk doing 28 sessions than it does if they do just the 5. So, and there are other data that are coming out that with newer, more precise machines, the majority of the people, well over 90%, are going to do well with a 5-session SBRT. There's also some evidence that killing may be better, but if you're going to have rectal bleeding or prostatitis or bladder complications late, you want to know about it and you want to slow the dose rate down. And that's what the prostate test can do. Now, I haven't heard good information yet. The original Prostox test was done where they validated using a CT guided machine. So they looked at what is the risk of a side effect if you got a high dose per day or low dose per day over more days. And that was guided with CT guidance. So there was more normal tissue being radiated. And I haven't yet clearly seen data that says that it just tells you don't want to radiate a lot of normal tissue, but you may have a patient whose disease is more sensitive. And could you, in fact, if you have a positive prostox and they're more susceptible to damage, lower the daily dose rate or the total dose to get a response, a better response. I read a study today on flash radiation, which is not yet done. They did 4 different types of solid tumors, not prostate yet, but in those tumors, a single dose of radiation was used. So it'll be interesting to see if that comes up for prostate. But these guys are looking at ways to cut down the risk. And between the combination of the prostox and the smaller margins with newer machines, I think radiation today is not the radiation of 5-10 years ago.
Can I add something real quick, Dr. Mark, when you're done?
You go ahead.
Yeah, okay. So the other thing was I wanted to do before the Prostox even came to my mind. I wanted to do the 5 because 5-day versus 28-day makes sense logistically. But my radiation oncologist said, no, he doesn't recommend 5-day course because my tumor was too close to the urethra. So he didn't want to try to always risk that or trying to lessen the dose when near the urethra to protect your urethra. He said, I'm here to cure your cancer. Try to cure your cancer.
So
Yeah,
what
so
I'm
that
going to
makes
tell you,
yeah.
what I'm going to tell you is that's marketing, because they didn't have access to a machine that can reduce the margins. The way you reduce these side effects is by having a machine that understands if there's movement and either turning the beam off or re-aiming the beam to just get the area you want and not normal tissue. And
Talk about the MRI guided machines.
MRI guided, CyberKnife, those allow you to cut that margin so it's less of an issue. And really with the better machines, I mean, if you just compare what you did, SBRT with the smaller margins, you have about a 60% reduction in early side effects. So what he's doing is making a story to make you comfortable on his machine.
Well, he does have a SBRT machine.
Well, yeah, but there are a lot. The thing is that SBRT is just the dose rate that you get it. It's not the machine. There are a number of machines that can deliver that dose over 5 days. But do they allow you to adjust the field treatment on the fly each day? Do they cut off if the beam moves, if you get a gas bubble or something like that? So, Hector, you said something about comparison on Proton. I'm not sure comparison with what.
Me? No, I didn't say that.
No, Hector. You
No,
put in
yeah, the question is for me, and please allow me to explain. I was recommended by this group to go and see Dr. Rod Ellis in Tampa General. He's a highly
Yes.
experienced gentleman, and he has tried everything, all kinds of radiations. And he was proposing 5 sessions with SBRT. Okay. And I asked him, well, what about the gel spacer in order to have certain protection against toxicity? And he said, well, it really doesn't change anything, and I don't do it. If you want to have a gel spacer, go and do it somewhere else, and then come here. So I mentioned him that I was also going to have a meeting with Dr. Fagundes at Miami Cancer Institute. He's the department head. He said, well, send him my regards and tell him what I'm doing. And I didn't have another meeting with Ellis because he was like down to business. He was like, well, are you going to be treated or not? Otherwise, when you get ready, come back. So in the meantime, I did some research and found that photons propagate pretty much endlessly.
Okay,
So
Hector, I know, I hear your question. You don't have to go into that whole story here.
No, but
First
I
of all,
just wanted to say that, talk about the Bragg effect for proton
I know
therapy.
that we know about it. We know about it, and I'll address that in a minute. Okay. First of all, the spacing gel is a mixed thing. If you are using older technology machines, there's a bigger margin and it doesn't adjust, and you have greater risk of radiating the bowel and the bladder, and the gel is definitely advised. UCSF doesn't use it. UCLA doesn't use it. Dr. Nagar in New York, I don't think routinely uses it. And it's just not something that everybody needs or uses. Dr. Rod Ellis uses a CyberKnife machine, which has real-time adjustment while the beam is on. It will move it, and if the prostate moves because there's a gas bubble in the rectum, that's fine. It will adjust for that. On the other hand, if you're doing proton, you have the Bragg effect, and all the energy is released at one spot, but you're getting ready to fart while the beam is on, and that gas bubble puts it down. You're taking all this energy and putting it into the bowel wall. Long and short of it is the Bragg effect is nice on paper. It helps them market a very, very expensive system. There's only one comparison study, photon and proton, for IMRT with 28 sessions, and there was absolutely no difference. If you're using a good machine, and that was with an older machine, comparing proton and photon, they saw no difference in outcome, no reduction in side effects. It's a marketing claim. The studies just don't say it is any better. And in terms of alternative machines, if you're looking at CyberKnife or the MR Linac, they have the MRIdian at Tampa General, if that's the area you're in. That has smaller margins. It has adaptive radiation therapy, so it can adjust if the prostate swells one day or shrinks the next. And compared to other CT, there's a 60% reduction in early side effects. So don't fall for the crap on proton. It's really a marketing thing, and there's no data. There's no data to support it.
Yeah, I saw that study, and actually, there's no fundamental difference. And even further, when I spoke with Dr. Fagundes, I told him, well, what about collimation? And for proton, they are not ready yet. They don't have the machine to collimate.
Right, and you're using two beams. When they do SBRT with proton, there's a lot more skin burns. The person who does more proton than anybody in the country is Dr. Rossi in San Diego. He runs a big proton clinic. And he has said that he does not feel comfortable with doing SBRT because of the skin burns with proton. The Mayo people, I think, are doing proton SBRT, but it's putting all that energy in through two beams, and you don't know where you're delivering the energy. Whereas with the CyberKnife or the MRI Linac, you know exactly where the beam is going, and it's getting the tissue you want because you can see better with an MRI. So that's my thought there.
Do you have
Anybody else?
any reference about the CyberKnife Center? It's not Tampa, a little bit south in Bradenton.
I don't know.
They have
I
one
don't.
center there, but
Yeah, I don't know the specific one, but you know, if you have an MRI Linac in the area, I think that's the state of the art, and CyberKnife is okay. But a standalone center of excellence, I think, is better than going to a standalone radiation clinic.
yeah.
You know,
But
Moffitt is an NCCN full service multidisciplinary cancer center, and rather than going to a private radiation facility, I think you'd be a lot better off because it's not just the machine, it's not just the one person, it's having a whole team of people that make the radiation work and make it safe.
yeah, I went to the Moffitt and they wanted to do brachytherapy, which
Well, it
not
depends who you saw
90%
there.
sure
Yeah.
that applies.
So you
And
could ask, you could go there, and Dr. Johnstone is the fellow there who does MRI Linac. But in the
yeah,
meantime,
I saw Dr. Julio Posen, which
okay.
is
Well,
a CCN member, but he was strong coming on brachytherapy. And,
yeah. There's no reason that you have to do that and go through a procedure.
Yeah, and at the Tampa General Hospital, they proposed me to get into a trial so they could do more focused radiation on the lesions and not that more on the healthy tissue.
Yeah.
And then they took
Hector,
it back, and they don't
yeah.
want it to be sued. So, yeah. Okay.
Hector, we started at 5 o'clock, and had you been here when we started, you would hear a whole discussion on focus. So I don't want to have to rehash all that again since we had gone over that before. I think we've got
Why 5?
Because at 5.
Because that's the time we start, Hector.
No. 5 p.m. Pacific time.
Oh, Pacific. Okay.
8 o'clock. Yeah, 8 o'clock your time. All right.
Yeah, I was late. I'm sorry for that. So, to make the long story short, I'm sticking with active surveillance for a while.
Well, if that's something that they say is appropriate, then that's always a better option. You can come back and treat if you should need it in the future.
Yeah, my decipher came low risk.
Okay, well, that sounds like a good thing.
Yeah.
And, you know, if you want, come back in again, and we can go through the story and update things. But for now, it sounds like you're on a good course. Do we have any last words?
I have a last word.
Then let Bruce go briefly, and then you can have the last word. Bruce, I take you're muted. You're still muted. Let me try again to unmute.
Oh, there we go. Just curious for my own. Is anybody familiar with the University of Miami and a person by the name of Dr. Sanjo Punham? I think Rick Davis said he knew of him.
Yes.
In reference to because supposedly he has a very good reputation in reference to active surveillance. Mark, I was just curious. Dr. Mark, I was just curious if you've heard of of Dr. Sanju Punam at the University of Miami.
I have not.
And Rick, you have, and you have some trust in him?
Yeah, I think I told you he's an excellent doctor who believes in active surveillance.
No, I got it. Just one of the things that I heard earlier was in reference to try to find out somebody who could also help be your guide and be your coach. And, I got 3 guys at the University of Miami, but nobody talks about any of the stuff that you guys talk about.
Well, they don't have the time. We try to fill in the gaps, but we have no hesitation in referring to Punam. He's very good, and he's a good navigator. But you have to also listen carefully and take in what it is that they're advising you.
Right. All right. Well, I guess I'll have more information after May 7th. So I appreciate everybody. Thank you very, very much for being so kind to me tonight. Thank you.
Okay, Rick, you're up.
So, yes, I want to apologize to everybody because in my haste and error on Friday, I sent out my high risk reminder to everybody. That's like 2,900 people by mistake, because it should have gone to about 700 or 800 people. Now, I should have said this when Dr. John was on the call, because Dr. John and I were going back and forth trying to get the right images to put in for his very excellent commentary on heart issues, which was helpful to everybody if you opened that high risk. And in addition, you got to see the black bears climbing up the tree in his in his garden, which he had sent to me because he knows I like seeing pictures of those black bears that live in his backyard. So I thought, oh, this will be good for all my people in the high risk recurrent advanced group, because they all know Dr. John anyway, and they'll enjoy it. But as it turned out, about 1,200 people saw that picture, which is a lot more than normal, and we only got 10 people unsubscribe. So it wasn't a bad job for those black bears. So that's what I wanted to say, and I hope you saw those black bears, and I hope you got a kick out of seeing them.
I guess we had to grin and bear it.
Oh, growl, growl.
Okay, so Ellis does have the cyber knife, Hector, and that's a good system. Anyway, we will. Are we 2 weeks now? We're back to the real second Monday
until July, and in July we have to do the same thing again, I'm afraid.
Okay.
All right.
Thank you.
Sorry.
Hope you had a good holiday and stay well.
Hold on a second, Dr. Mark, after everybody's gone, or any of the organizers can stay in.